Now going to the next speaker علم من أعلام جراحة الأورام في صعيد مصر الأستاذ الدكتور هشام حمزة. اتفضل سعادتك. العنوان المحاضرة Evaluation and Surgical Treatment of Thyroid Nodules and the Cancer During Pregnancy.
السلام عليكم. أنا متشكر جدا لدعوتكم الكريمة وشرفت بوجودي معكم النهارده. الحضور الكرام، الموضوع كبير. أنا هحاول أتطرق لجزئية صغيرة في مش كل الثايرويد نوديولز، لا أنا هتكلم على النون فانكشنينج بارت، وهنحاول التوك تبقى كونسايزد، هي من بدايتها او لاخرها عباره عن الهوم مسج او الريكومنديشنز، وهنركز فيها على نفهم احنا اللي هو ما معلوم عند كل الجموع، احنا ليه بناخد قرارات ليه الثايرويد نوديول الثايرويد كانسر ده بالذات الديفرنشيتد ليه اندولان ديزيز، على اي اساس بنختار التايمينج اوف سيرجري، على اي اساس بنعمل المانجمنت للبيناين ثايرويد نوديولز. بسم الله الرحمن الرحيم. A thyroid nodule is defined as discrete lesion in the thyroid gland that is radiologically distinct from the surrounding parenchyma. Thyroid nodular disease are common during pregnancy, with increase in newly developed nodules and also increase in size and number of previously existed nodules. Thyroid gland size normally increase by 30% during the first and third trimesters of pregnancy. TSH level fluctuates during pregnancy as it decreases during the first trimesters and then return to normal. Regarding the effect of pregnancy on thyroid gland, we could explain it by two mechanisms. Increase the level of human chorionic gonadotrophin hormone and the increase in circulating estrogen level. Both TSH and HCG hormone are glycoprotein hormones with a similar structure and encoded by the same gene. HCG hormone stimulates TS receptors, leads to increase the activity of the thyroid gland. TSH level decreases mainly during the first 12 weeks of gestation, then back to normal. HCG stimulating effects on thyroid gland can be noted in diseases causing very high level of HCG as gestational trophoblastic disease, with less than 10% of these patients presenting on manifestation of hyperthyroidism. Estrogen exists its effect through more complicated mechanism. It has indirect effect through increasing the serum thyroxine binding globulin. The direct effect through estrogen receptor presented on the thyroid gland. There is two types of receptors, A and B, are intracellular nuclear receptors that exist in normal and neoplastic thyroid cells. Estradiol binding to receptor A enhances cell proliferation, while receptor B inhibits this effect and induces apoptosis. Some recent studies show different levels of expression of receptor A and decrease in receptor B in malignant thyroid cells in comparison with normal cells. Another study suggested an association between receptor A expressions and the aggressiveness of diseases at presentation and relapse. هنحاول to simplify how to approach the thyroid nodule during pregnancy, how to diagnose, how to assess risk. Till now, there is no consensus regarding screening for thyroid dysfunction, neither during pregnancy nor for thyroid nodules. If a thyroid nodule is found during physical examination or accidentally, an ultrasound examination, it should be assessed for suspicious of malignancy. These sonographic criteria that indicate a fine needle aspiration cytology, hypoechogenicity, irregular nodular margin, absence of peripheral halo of nodules, increase intranodular vascularization, nodules taller than wider, presence of microcalcification, and lastly, laterocervical lymphadenopathy. According to the American Association of Clinical Endocrinology, استخدموا أو two criteria for planning approaching للثايرويد nodules, clinical criteria و sonographic criteria, وحاولوا يعملوا بيها stratification عشان يعملوا mapping للapproaching للثايرويد nodules. الclinical criteria in favor of fine needle aspiration classified as clinical 2, ودي من ضمنها history of head and neck radiation, compressive symptoms, nodules position posterior or adjacent to thyroid capsule or trachea, history documentation of nodular growth, history of progressive growth more than or equal to 50% in volume in less than 1 year, especially the solid component, or 20% increase in one dimension of the nodule, sudden enlargement, even patient preference or anxiety, or protocols requiring documentation of cancer. ده الرانكينج، ده الستراتيفيكيشنز اللي عاملاه الامريكان اسوشيشن اوف كلينيكال اونكولوجي عشان نبسطها اكتر في ال NCCN guidelines. Estimate risk of malignancy and fine needle aspiration guidelines for thyroid nodules. In highly suspicious, the sonographic finding includes the following: solid hypoechoic nodules, solid hypoechoic component in partially cystic nodules with one or more of the following features: regular margin, microcalcification, taller than wider, rim of calcification with a small extra soft tissue component, and evidence of extrathyroid extension. The risk of malignancy, estimated risk of malignancy in such nodule حوالي 70 to 90%، ودي recommendation فيها fine needle aspiration if the size more than 1 equal or more than 1 centimeter. The intermediate risk nodules include the following: smooth margin without microcalcification, extrathyroid extension, taller than wider. The estimated risk of cancer 10 to 20%. Recommendation برضو fine needle aspiration cytology and all lesion equal or more 1 centimeter. Low suspicious isoechoic or hyperechoic solid nodules, partial cystic with eccentric solid areas without microcalcification, irregular margin, extrathyroid extension, taller than wider. Estimated risk من 5 ل 10%. والrecommendation for fine needle aspiration on a size equal or more 1 centimeter. At very low suspicious spongiform or partial cystic nodules without any of the sonographic feature described in the low, intermediate, or high suspicious pattern. Estimated risk of cancer less than 3%. Consider a fine needle aspiration at a lesion size equal or more than 2 centimeter, أو observation without fine needle is also a reasonable option. The benign, purely cystic nodules, no solid components, the estimated risk of cancer less than 1%, no indication of biopsy. Fine needle results are best evaluated based on Bethesda classification, follow-up, and malignancy risk are as follows. 1, non-diagnostic or poor specimen. We have to repeat the fine needle with ultrasonographic guide, estimated risk of cancer, in such case, 5 to 10%. Benign nature, clinical or sonographic follow-up, estimated risk of cancer less than 3%. If the result atypia of undetermined significance or follicular lesion, undetermined significance, cerebral fine needle aspiration, molecular testing, or lobectomy, estimated risk of cancer من 6 إلى 18%. 4. Follicular neoplasm or suspicious of follicular neoplasm, molecular testing plus lobectomy, estimated risk من 10 ل 20 إلى 40%. وفي حالة لو كان الهيستوباثولوجي non-invasive follicular thyroid pathology, estimated risk من 25 ل 40%. 5. Suspicious of malignancy, total thyroidectomy or lobectomy, estimated risk من 45 ل 60%. 6. Frank malignant, total thyroidectomy or lobectomy in certain conditions, estimated risk of cancer من 94 ل 99%. الفيز الثاني في السبيك في التوك هتبقى عن الابيديمولوجي والريسك فاكتور اوف كانسر ان بريجنانسي. The incidence of thyroid cancer ودي الريسك فاكتورز in general في thyroid cancer is rising all over the world. The increase is affecting all ethnic and age groups and increased risk among women below 45 سنة. Women are more affected by thyroid cancer more than men. History of exposure of ionizing radiation, iodine deficiency, all these factors are well-established risk factors. Increase in the incidence of differentiated cancer is not accompanied by increase in mortality. This reflects the indolent nature of the disease. Thyroid cancer related to pregnancy is defined as the diagnosed during pregnancy or within 12 months of childbirth. Thyroid cancer is the second most common malignancy during pregnancy, preceded only by breast cancer, with an incidence of 13 per 100,000 live births. Female dominance and age-specific increase in incidence in women during childbearing period suggested a possible role of sex hormone in developing thyroid cancer, especially differentiated thyroid cancer. وكل ده epidemiologic based. حاولوا يفسروا القصة دي أو يأكدوا المعلومة دي. The California Teachers Cohort Study investigated the effect of menstrual, reproductive, and other hormonal factors, including exogenous hormones intake, on developing differentiated thyroid cancer. This prospective study included more than 117,000 women, has suggested an association between the late age of menarche, long menstrual cycles, and increase the risk of differentiated thyroid cancer. On the other hand, an EPIC study, which also a prospective cohort study with a large sample size, more than 345,000 women, followed for a median of 11 years, didn't find strong association between reproductive factors and the risk of developing thyroid cancer. Both studies, however, identified a positive association between recent pregnancy and thyroid cancer risk. A meta-analysis was conducted to solve this issue with 21 studies including more than 406,000 cases. This meta-analysis suggests a strong association of parity with the risk of thyroid cancer. It confirmed the previously noted observation of transient increase in risk of thyroid cancer. هو في 3 أسئلة أنا كنت عاوز أجاوب عليهم في التوك ده، لكن الوقت الظاهر مش هيبقى كافي. هخش على طول على المانجمنت اوف ثايرويد كانسر. الايم اوف سيرجري او المانجمنت اوف ثايرويد كانسر في البريجننت ليدي: كنترول اوف مالجنسي، overcome الهرمونال disturbance after thyroidectomy, avoid drawbacks on fetus, timing of surgery. Timing of surgery and the hormonal monitoring of women with thyroid cancer are important point to be discussed while treating cases presented with thyroid cancer. The NCC guidelines provide treatment recommendation based on Bethesda classification. Bethesda 3, in high clinical radiologic suspicious, consider lobectomy and total thyroidectomy. In low suspicious, fine needle aspiration, molecular genetics, or diagnostic lobectomy. 4, high risk lobectomy or total thyroidectomy, low risk with Thyroid. Consider diagnostic lobectomy, molecular diagnostic, surveillance. Bethesda 5 and 6 go according to the surgical guidelines. In case of 2, the molecular diagnostic are not informative or the sample is insufficient, degraded, then the nodular surface lobectomy in selected situation or repeat biopsy is considered. If the molecular diagnostic are suggestive of malignancy, consider lobectomy or total thyroidectomy. Standard treatment زي ما قلنا total thyroidectomy or lobectomy in certain situation. In a pregnant woman, both maternal and fetal outcome should be considered. According to the Endocrine Society of Pregnancy-Related Differentiated Thyroid Cancer, thyroidectomy after delivery for patient in the 3rd trimester with no evidence of advanced disease or without rapid progression. Thyroidectomy in the 2nd trimester for all other cases. However, in some patients whom diagnosed during the 1st trimester of pregnancy, tumors may show aggressive behavior, aggressiveness, locally advanced histology, metastatic cervical lymphadenopathy, severe compressive symptoms, significant growth of thyroid nodule, more than 50% in volume or 20% in diameter. In such situation, surgery should be carried out during the 2nd trimester and not to be postponed till delivery. أنا هكتفي بهذا لأن الباقي اتغطى quite sufficient بالزملاء الأفاضل والدكتور دياب بيه، وشكرا